At the end of this episode, you should be able to identify who may order the transport of a patient against their will, define in need of voluntary care or treatment, define likelihood of serious harm, identify when EMS may be asked to assist in MHA transport, understand MHA transport requires the appropriate documentation, and understand when MHA is not appropriate.
Well, there are two categories of individuals under New York State mental hygiene law that are authorized to order the transport of individuals to a psychiatric facility for evaluation due to their mental illness. And the two categories, one would be mental health clinicians that are designated by the Director of Community Services, or which we commonly refer to as the County Mental Health Director, or DCS, Director of Community Services designees. So the DCS designees is one category, and those are mental health clinicians. In Monroe County, excuse me, most of the psychiatrists in our public sector are DCS designees. We also have individuals on our mobile crisis team that are DCS designees, and then there's a few other individuals. I'm a DCS designee. There are senior, advanced, or senior level clinicians at some of our outpatient providers are also given that authority to do that. So that's one category. The other category, of course, would be law enforcement. So law enforcement under New York State Mental Hygiene Law, Section 941, have that, are able to do that as well.
So New York State law allows certain individuals to take a person and transport them to a psychiatric facility for assessment, evaluation, and possibly treatment. And those individuals are first police or peace officers. So let's say police officers in the function of their during in their duty have the power to transport a patient against their will to a hospital if, in their judgment, they see that this person displays evidence of what they would consider mental illness. So we're not asking police officers to be professionals in this field, but any average person looking at a person saying, this person needs help, that's the criteria that a police officer goes by to take a patient to a hospital. Other individuals are what we call DCS designees in the community, which is Director of Community Services. So those are individuals kind of designated by the County Office of Mental Health to have that power. Usually they are mental health clinicians. DCS designees in a community are all the psychiatrists in that community who apply to have that designation, and some mental health clinicians, usually social workers in the community. So to recap what I'm saying, police officers, psychiatrists, and certain mental health professionals who have that designation in a county have the power to transport a patient and bring them to an emergency room for evaluation.
The 911 center actually has a list of all of the approved DCS designees, so that if there's ever a question, I know at times law enforcement has questions about that, or EMS providers may wonder if the person that actually signed the sheet that they see, there may be something about that presentation that doesn't feel right, and it's a simple call to 911, and at the supervisor's desk there, they have a current up-to-date list of all of the DCS designees that are authorized to do that.
New York State allows law enforcement officers and designated community mental health providers to order the transportation of a patient against their will to acute psychiatric care. EMS personnel may call the 911 center to verify which community mental health providers are designated to order MHA.
That's an important question. In need of involuntary care and treatment is an individual first who has a serious mental illness. So that's an individual who has a serious mental illness. Mental illness as defined by having a brain disorder, usually meeting criteria for a diagnosis, psychiatric diagnosis. And that person has to display some evidence of harm to self or others. What we mean by that is threats of suicide or threats of harm to someone else, or behaviors that are of concern because of self-harm or harm to others. And then also that this person has to show some inability to really make decisions for themselves, in the sense that this person is saying, I don't need help, while clearly they are displaying some behaviors of concern. Those are the criteria that we go by to decide that this person is in need of involuntary care and treatment. Having a mental illness, danger to self and others, and lack of insight into their illness. Likelihood of serious harm is substantial danger to self and others. And that's also a legal language, which means that it's basically a person who's showing some evidence of harm to self or others. This is usually understood to mean less than 50%. So basically, likelihood of harm to self and others means that the person has to show some evidence. If someone is stating that they are depressed and that they are having suicidal thoughts, that qualifies. We don't have to wait until that person actually does something to harm themselves. So it should not be understood to mean that the person is very likely to hurt themselves. We are not trying to guess in this instance whether the person is going to harm themselves or not. If there is any evidence of concern, that qualifies as likelihood of harm to self and others.
The likelihood of serious harm to self or others, means, it used to be translated quite simply into somebody being suicidal or homicidal. And most of us, laymen or not, can understand that a likelihood of serious harm could come about because someone is voicing suicidal thoughts or homicidal ideation. In the statute, there's also a phrase that says, or other conduct that demonstrates the person may be dangerous to himself. And that other conduct is it broadens that a bit. And what that means is it includes the person's refusal or inability to meet his or her essential need for food, clothing, shelter, or health care. So an example of that might be if somebody was, because of their mental illness, was disoriented and say, psychotic to the point where it's one of our cold, northeastern Rochester days here, that it's 0 degrees out, but they're walking down the street with shorts and a t-shirt, and when approached by law enforcement, think they're in Hawaii and they're just going down to the beach or something like that. Now, they're not voicing any suicidal ideation, there's no homicidal ideation, but in the context of a mental illness, clearly there's dangers to self, to be able to provide shelter, health care, etc.
In need of involuntary care and treatment is defined as the patient displays the behaviors or thought processes indicating mental illness, lacks decisional capacity. The result of these is that they are dangerous to themselves or others. Likely to result in serious harm is defined as the patient displaying behavior that can result in significant injury to themselves or others. This does not necessarily have to be behavior with lethal potential.
Okay, so let me imagine a scenario where law enforcement either on their own during a patrol see a person maybe walking close to a bridge somewhere, and they stop and talk to that person, and that person will say to them something to the effect that I'm not feeling very well, I was having these thoughts of jumping off a bridge. That's a kind of a clear scenario where a law enforcement officer has a responsibility to transport that person under 941 statutes to a hospital for care and treatment. A similar scenario with law enforcement would be a parent or a friend of a person calling 911 and saying, I have a friend or family member and I am concerned about their safety. The police officers will respond to that call, and again, talking to that person, seeing themselves evidence of mental illness in their own judgment, and evidence that the person is potentially harmful to themselves. Person says, I'm sad, yes, I'm depressed, yes, I have suicidal thoughts. That's a clear indication that they need to be in the hospital. So in an outpatient psychiatrist setting, usually it is a mental health professional seeing a person in an office setting. Person comes for their therapy appointment, therapist is talking to them, and during the conversation they discover that this person is not only having increased symptoms of depression, but now they are talking about suicide. Therapist is concerned, they call the psychiatrist and say, Mrs. Jones is having more suicidal thoughts, I'm concerned, I think she needs to be in the hospital. The psychiatrist at that time fills out a piece of paper called a 945 based on the conversation with the therapist without actually seeing the patient themselves. And the therapist will be calling 911 and saying, I have a 945 completed on Mrs. Jones and I'm requesting that she be transported to the hospital.
Let me explain the difference. That while I said both mental health clinicians or DCS designees are authorized to order the transport of individuals, as well as law enforcement, let me make it very clear that there are two criteria that need to be met before that paperwork or order is initiated. One, on the law enforcement side, the person has to appear to have a mental illness. And I say appear because that's the word that's in the statute under 941. And despite the good training that many, or all of our law enforcement officers have, there's not an expectation they're going to make a definitive diagnosis or the definitive presence of a mental illness. It appears. So based on the person's behavior, sometimes their environment, and oftentimes, what they're saying, their verbal cues. Now, on the other side, on the mental health clinician initiated 945s, or what we call our mental hygiene arrests, although I do want to mention that they're not really arrests in the criminal sense. There's no criminal record. It's really more appropriately called mental hygiene transport or mental health involuntary transport, but we've used here historically mental hygiene arrests or MHAs. On the mental health clinicians that are initiating the 945s or the MHAs, the statute is a little bit clearer. It says the person has a mental illness. And so it's a subtle distinction, but I think that's an important one because the standard is slightly higher if you're a mental health clinician and you're initiating the involuntary transport. You have to have some indication that the person actually has a mental illness.
It is important to remember that police officers and outpatient mental health providers have different criteria to order an MHA.
Unless they feel that they have enough on medical grounds to transport the patient against their will. If it's a mental hygiene issue, they have to involve police officers because paperwork needs to be completed by the police officers to allow transporting that person against their will. Again, we have to take very seriously that the fact that we are taking a person's freedom, transporting them against their will, and in effect incarcerating them in that ambulance and taking them to a hospital. That's a very serious matter. People do take it seriously. EMS providers do take it seriously. Police officers obviously do take it seriously. And we have to remember that whenever a mental hygiene arrest needs to take place, a police officer or a psychiatrist in the community needs to be involved. Those are the only people who can order patients to be transported to a hospital. But you are absolutely right that the police officers are the main designated persons to transport a patient to a psychiatric facility, which is important to remember because that's one of the misunderstandings of mental hygiene arrest, is that oftentimes, I shouldn't say oftentimes, but sometimes patients are transported via ambulance without necessarily the paperwork completed and without a police escort. That creates a little bit of a gray zone and a misunderstanding of the statutes.
The appropriate Section 945 paperwork must accompany every patient under MHA.
Yes, there are these are difficult questions to deal with because there are so many gray areas in this. And dementia could fall under the mental hygiene law if the person is displaying psychiatric symptoms enough to cause harm to themselves or others. But there are cases, like you mentioned, where a patient with either dementia or any other medical illness, where a person is clearly in need of treatment, but may not fall under the mental hygiene law statutes. So an example of that is, let's say, a patient with dementia, delirium, confusion, a urine infection. Clearly that person is confused, unable to make decisions for themselves. However, the treatment that is deemed necessary for that person is a medical treatment in a medical facility as opposed to a psychiatric facility. So the patient is refusing care or even unable to accept or refuse care sometimes. And there has to be a way to basically transport that person to the hospital without their consent, if you want. In medicine, there's a doctrine called the emergency doctrine. So a person in need of care and treatment who is refusing care, if they are not able to understand the nature of their illness or be able to reason and say why they are refusing care and treatment, we are allowed to treat them anyway, because this is what an average person would want for themselves, and that specific person is not able to make decisions for themselves.
Patients who are unable to display decisional capacity are not necessarily transported under MHA laws. They are often transported under the doctrine of implied consent, the emergency doctrine.